Hey guys, how's it going? Another live post today, I guess another week. Robert the physio in the house. How's it going, Rob? We got lots of people joining up, so hopefully you guys told your friends and family and everything just to make this even more popular. So we do have a guest speaker in today. He's gonna be joining us pretty soon. A very good friend of mine, a brother if you will. He'll be attending and talking about tendinopathy and rehab and things like that. So he's just joined. And then let's do some screen sharing with Yehia. And I'm just opening up Zoom as well. And we're on Zoom. How's it going, Zoom peeps? So today we're gonna have Yehia, a good friend of mine, a physio in Toronto, who's gonna be joining us on Instagram Live. So the individuals on Zoom might not be able to see this, but you should be able to hear it. So if you do have Instagram, try to switch to Instagram. That way you can see what's going on and hear what's going on, because we're going to be doing the screen sharing with Instagram, and then we'll see how that works. So if you do have Instagram, try to go on there. You should still be able to hear the audio from Yehia, and that way you can hear what's going on. So hello everyone who's joining in. We're going to get started in a few minutes. Yehia is just connecting. Should be connecting soon. Let's see here. So I'm trying to add Yehia to this. 1 second, technical difficulties.
Ah, there we go.
There we go. Okay, so we got Yehia in the house.
What's up, Sonny?
Hopefully everyone on Zoom can hear this. You're going to hear some interesting things, that's for sure. So maybe we'll tell everyone on how this relationship, we won't go into the exact story of how this relationship started. It is like PG rated, but it often takes like 20 to 30 minutes to explain, and I do like telling stories. But Yehia and I met. We were both in Vancouver at the same time, but we never met in Vancouver.
That's right.
We met in Halifax. Which university was that?
Good old Dalhousie University, my friend.
Dalhousie University was where we met, and then became obviously great friends. And then we were in Alberta together.
Yeah, I moved to Edmonton because Sonny was there, and I was taking a year off. And Sonny was like, "Why don't you come by and I don't know, spend the year here?" And I was like, "I don't see anything wrong with this plan."
Yeah, it was like,
I moved to Edmonton and stayed there for 4 years, man. We lived together for 4 years.
Yeah, we were roomies.
Uh-huh.
It was funny because Yehia was like, is Alberta a good place to work? And at that time, yes, it was. And then when he decided to come, I was like, oh, shoot, better be a good place to work. I was a student at the time, so I was like, who knows? It was all speculation. I'm like, I just hear oil and gas, and this and this and this. But everyone on Zoom, can you hear what's going on Instagram? Hopefully you can. If you have Instagram, try to switch to that. If not, I will be recording this either way. And maybe I'll do the recording of Instagram. And that way everyone can see Yehia's beautiful face. We got some people joining up, which is good. So, and then, oh, hey, Brittany Wade has joined. She'll be joining us on Thursday for pelvic health. So that's going to be exciting.
Hi, Brittany.
2 Toronto guests. Very lucky to be, involved with the big city, the big town.
The city slickers and the country folks.
The city slickers. I like big cities. Toronto's great. It's been great to me, and I know I'm getting off topic, but we do have a few minutes to wait for people to join. But Brittany says, "Hey guys, what's up? Can't wait to have this happen and then have a global takeover with physio." So
Brittany's doing her session on Thursday, right?
Brittany's doing it on Thursday. Yeah.
Nice. Yeah.
So
that should be a good session for sure.
Oh, for sure. I'm very excited about that. A lot of people have been asking about pelvic health, and I think it's a very good topic, something that I obviously have limited training on. So I think it'll be great to have that input.
Yeah.
So today we're going to go over some tendinopathy rehab. Yehia's agreed to literally do 100% of this, so I'm just going to take a nap on one of the beds, one of the 6 beds that are empty currently.
He didn't even ask me. He just like, it was presented to me as like a threat more than a request. He's like, "You're doing the whole thing," and I was like, "Yes, sir. I'll do it. I'll do it."
I'm not aggressive, but when it comes to this kind of stuff, yeah.
When it comes to friends and family.
When it comes, well, that's what my mom said, right? Like our health and well-being doesn't count because we're family.
Yeah, exactly.
What
I'm gonna do is sue you.
Other people take care of their family like extra good. Whereas our parents were just like, "Nope, this is not going to happen. You're going to be your family. So that way, you know, you're not going to benefit off."
No, it was a pleasure doing it for sure. Thanks for having me on your live feed.
I do thank you here quite a bit for doing this with us. The goal is to combine with other physios, like connect with other physios.
Yeah.
And then this is extra special to me because Yehia is a brother to me and a great friend. So for me, this is like a great treat.
Yeah.
So it's actually wild that like going to school, seeing each other going through school was wild, obviously, lots of good times. And for now to be professionals and do this is like, I could have never thought of this. So, I mean, yes, it's a terrible time in terms of what's happening with the world, but like this kind of stuff I don't think would happen without it, right? So I think we've done a good job in terms of staying connected and then also being connected as professionals. So I think this is great to do. Everyone should be doing it. Yeah.
Awesome. I'm glad to be here.
That's all I got to say about that. Some different accents might come out. I get pretty excited with Yehia around, so I'm gonna go into a screen share mode. And if you want to intro anything, Yehia, let me know, and then I can pull up the PowerPoint and point my camera to it.
Sure. I might as well pull the PowerPoint up myself because I don't think I'll be able to see it on this screen.
Okay, so Yehia's pulling up the PowerPoint as well. I'm glad to see everyone. Hello, everyone. Each week it's kind of nice. We get more and more people joining up, so continue spreading the word. Take some pics of you doing this stuff, of the rehab, and then we can share it in our story. I think this is a really good idea. And,
on the same frequency as you're talking about, like how as horrible of a time this is, like it's giving us the opportunity to actually all come together and share different parts of our experiences or different parts of our knowledge that didn't present itself in previous times. Like you're starting to get a following, and I love how the idea of you trying to like interview or trying to like get people that are completely has nothing to do with your clinic to bring it on and they kind of share the knowledge, and that's very like admirable for me to see that you're doing. So good job, man.
Appreciate that. Thank you very much. I appreciate that.
You done good. You done good.
Once we open up, then hopefully we do even better.
Hopefully have something of substance to provide.
Sorry. That's my
guys, that was the presentation. You guys did great.
We're going to have so many videos that I said last week, I'm just going to tell patients, click that video, see you later. No, I won't. I'll actually treat. I miss treating. I miss actively treating patients. So, yeah. Awesome. I'm going to flip this camera over on my end, and we're going to go to this wonderful PowerPoint. Hopefully everyone can see that. Yeah. Should be good.
Good to go?
Yes, I will go to the next slide.
All right. So just a quick introduction. My name is Yehia. I'm a physiotherapist in Toronto. Um, what I'm intending to do with this presentation is give common information about tendon and tendon pain. I'm going to go through details what that is and what is a tendon. But this information is intended for people who are not physios one, but also for physios who can benefit from it. But so I'm not using a lot of physio jargon, as so to speak. All right. So we're going to start. I'm talking about tendon and tendon pain. What is a tendon, first of all? Um, think of a tendon as a structure or a fibrous tissue that connects the muscle to the bone, in opposed to ligament, which is connects bone to bone. They both have their role in stability, but what tendon more specializes in is the actual movement of the joint, because when the muscle contracts, it pulls on the tendon, and then the joint moves, and that's how we basically walk and do anything really. So what its main job is to transmit the force, and that's important. So keep that in the back of your head. I'll tell you why that is important, because a little bit of physics, the line of force of where the force is applied is important, and how we are structured in general is ideal for maximum muscle force contraction. To give the most out of the muscle, to do a bicep curl, to do a squat, to walk, the muscle is structured in a way to apply the force onto the tendon in a certain way, and that will give you the most bang for your buck, so to speak. So, and there's also two tendons, one in the origin, one in the insertion. So that's that. And next slide. This is a general picture of sorry about the side. Yeah. So
Sorry,
this is structure of the.
cut out.
Sorry, you guys can hear me now?
Yeah, we're good.
All right. So this is a structure of the tendon. This is how the tendon looks for the visual learners out there, and you can see how is it like just like fibers in fibers, and wrapped in more fibers, wrapped in thicker fiber, wrapped in the whole structure of the tendon. So it could be applied in different forces. All right. So what happens when you hurt a tendon? So when you hurt a tendon, if you usually heard the word tendinitis, is usually any iritis in general is inflammation. So that's the word, the Latin word for inflammation is itis, when you attach the back to the end of the word. So tendinitis is inflammation of tendon. I'm going to use tendon pain because I'm going to talk more than just the inflammation. So when you hurt a tendon, tennis elbow, golfer's elbow, patellar tendinitis, Achilles tendinitis. A very common one is rotator cuff tendinitis. All these are irritation of the tendons that pertain to that particular muscle or muscle group. So two things happen. There's a local effect and a systematic effect. Or systematic effect means it involves your whole body, your whole system, right? So not just localized pain. So I'm going to talk, for example, about tendon in the shoulder, or the rotator cuff tendinitis. When you hurt your tendon in the first phase, when you just hurt it, what you tend to do is you kind of irritated the structure. So there's a lot of like inflammation in that area. It's hot, it's puffy, it's swollen, right? And then what we tend, and then you see a little bit of pain with movement. We tend to get out of these movement patterns that causes you these type of pain. So that is on the local effect. As you say here, the swelling, warmth, and redness. Now, what we usually tend to do is put an ice pack on it, ignore it, goes away, pain goes away. Pain goes away is another thing. Like if you listen to Brandon's previous lecture about pain, that should give you an indication that structure damage does not necessarily correlate to pain. But anyways, so you put an ice pack on it, maybe do some exercise, go to your physio or your chiro, go do some exercise, and it feels good, and then you go back to your activity. But then you find that it hurts, and then you start noticing on the other side, you're starting to get the same problem. And you're like, what's going on? I treated this area. I took the pain away from this area. And here's why. It didn't necessarily have gone away. The injury is still there. The tendon is actually still compromised, so to speak. what the research have found that on a systemic level, on a whole body level, we are finding actually deficits on the other side. So when you have injury, a tendon injury here, and you leave it for a long time, the other tendon gets affected as well. Although they're not connected physically, they're starting to see sensory injuries or sensory deficits. So temperature, you feel less temperature here. You feel different pain levels on the non-injured side. Even though I heard this side is kind of following suit with that. So what they found is actually when you injure a tendon for a long time, because the tendon is innervated or has a lot of blood supply, but also has a lot of nervous supply. There's a lot of sensory nerves that kind of tell us where our joint is. There's a connection, a big connection to the brain. Now, I'm not sure if it's on. So the next slide, Sunny, so this is on the local level. You can see there's structure damage on a very local level. But if you go quickly just to the next slide, Sunny, this is called the homunculus. A general idea of the homunculus is every part of your body is represented, is mapped out on the brain. It is mapped out for sensation and sensory issues, and it's also mapped out for motor issues. So you can see the part of the hand is represented a lot bigger than the part of the foot. That means there is more, not necessarily more muscles, but there's more representation that the brain is able to fine control your fingers a lot better than fine control your foot. That is why one of the reasons it's a lot easier to type with your fingers than it is to type with your toes. So when you injure your shoulder muscle, your tendon in the shoulder muscle, and you leave it for a long time and not address it properly, what happens is because you have developed a compensation pattern to get out of that pain. So instead of going up like this, you kind of do a little maybe compensation to get out of that pain range. That getting out of the pain range is a compensation pattern movement. That registers in the brain, if you do it enough time, that registers in the brain, oh, we're updating the movement and this is how we're gonna move now. And that's very important because if you're a pitcher, for example, and you pitcher back here, but this movement caused you pain, so you kind of maybe do it a little bit weird and a little bit differently, this is how you're gonna register, your brain is gonna register, it's gonna change the homunculus representation there to represent this new motor pattern. We call that a motor pattern because it's a pattern of movement, like a movement pattern. Now you do that enough time, as I said, it changes the brain representation, which is good for a short period of time because you're getting out of pain. But when you do it for a long period of time and the pain goes away, you have treated only the pain section. But what is left is actually the compromised movement pattern. So now you're left with a poor movement pattern. Now let's go back to the initial slides when we talked about force. When we talked about force, we talked about how we're structured as of right now, as the best of my knowledge. How we're structured right now, the forces applied by the muscle is optimum, is the most efficient way to apply a force to that structure, to the tendon structure. When we do a compensation movement pattern, because we had pain or trying to get out of that pain, what ends up happening is we are rearranging the forces applied to the tendon. Therefore, the tendon has to lay down more structure, and that's why tendinosis becomes an issue. Tendinosis is the progression of tendinitis, where the structure becomes a lot thicker, and you can actually feel it just sluggish, and it feels a lot thicker, and maybe sometimes in the Achilles and your calf muscle, feel like a little bump. That's really long time. You should not leave it for that long. But anyways, so going back, so now we talked about, just quick recap, on a local level, there's inflammation, there's redness, there's warmth, structure damage like you see here. But on a systemic level, the whole system is involved. We're actually changing the structure of the brain, and we're changing the structure of the shoulder. Last thing I'm going to say about that, when we measure, and this pertains more to physiotherapists and healthcare providers, when we're measuring strength, and in order to see if that patient has decreased pain in the shoulder, when we do an isometric contraction, we're not moving the joint, we're just resisting against your other hand, for example. Strength is not changed with tendonitis. With any tendon pain, they haven't found any change in strength per se. So we cannot use strength as a measure for, oh, I'm better, right? Because we have to use what the tendon is intended is a load applied force, which is how to apply, like in movement, basically. That's how we measure if tendon is going to getting better. So that was my spiel, so to speak, and how we change on a local level and we change on the whole system.
I guess with strength testing, that could be a lot of empty and like feels because you're in pain, so you're not going to resist. That's why I would assume like clinically people find decreases in strength just because like it hurts, so you don't want to resist. But if you're the strength is actually there.
Sorry, I should have clarified. I'm talking about in the end of rehab. So at the end of when you're feeling better, and we use strength, and it usually doesn't register pain, so you can push harder. But that does not necessarily mean that the tendon has healed. But yes, what you're saying is initially in the initial phase of injury, that does cause pain and it does cause weakness because it's an empty or pain end field.
Okay, that's interesting. Yeah. That article you shared with me was quite interesting. Definitely.
Oh my God, yeah.
Taught me quite a few new things as a physio, and like that's where we talked about bridging the gap between research and clinical skills is to bridge, to that skill transition, the knowledge transition. And I think what Yehia hits with this is quite a few new, well, I wouldn't say new things, but things that have been around and have been researched more now.
Exactly.
So I think that's great for the physios. So for the physios or new graduates or students, like definitely a good idea to contact either one of us and we can share that article.
Absolutely. So it's a concept article. Like it kind of like pushes the envelope in a lot of things.
Yeah, like it was definitely
a lot of research.
Very interesting. Like nowadays, researching as a clinician is very interesting because you get to research what you want to research. Whereas school, sometimes you're like, well, I don't want to read this, but I should. But now it's like you're actually invested in reading.
Exactly, and that's
good.
Yeah. So the last thing I want to talk about is the exercise part of it. Now we know this information. So what? So I'm quickly gonna go over what we used to do, or what is traditionally used in physios, in clinics, what is traditionally used as a treatment method to treat a tendon injury, wherever it is in your body. You're gonna find a lot like do 10 sets of 3, for example, or the eccentrics, which is like normal up, and then you're gonna go slower on the way down. What they found is those exercises, although they change strength, so that does make the muscle stronger, and although they change pain, which so decreases in pain, it doesn't do much for the structure of the tendon itself. So what happens, because it doesn't change anything in the rewiring of the homunculus that we saw earlier. So the new exercises that they suggested is something with an external. I'm gonna move so I can demonstrate the exercises. Can you see me now?
I can, yeah, that's pretty good.
So the new exercise that they found was it has to be with an external cue. Now, what does an external cue pertain? Basically, is a metronome. So if you download an app and it has like a beep, I can't do it right now because I'm using the same phone. So if you download a metronome, it gives you an external cue. So you're not counting; it's something from the outside that's counting, and you're timing your movement to address that tempo. So if you don't know what metronome is metronome is something that gives you tempo. So it goes beep, beep, beep in equal intervals. So you're gonna get a weight, and since we're in quarantine mode, you can drink anything. Right now I have a jar of dates.
I can, sorry to interrupt. I can pull up a metronome on YouTube and play that if you want.
Oh, yeah, go ahead.
Which kind of frequency do you want?
Just like a slow frequency.
Okay, let's try this 60 beats per minute and see what you think.
60 beats? No, that would be too fast.
Too fast?
Yeah.
What about like
Let's
40?
play something and we'll talk, just to get an idea.
I'll do 40 and yeah, I'll just play it right now here. 1 second. Can you hear that?
Yeah. So you guys hear that every time there is that beat, you should be, so this is an exercise given common for tendon injuries. You should be either at the bottom of the movement or the top of the movement. This is my range, right? I'm too fast. Now you can play with it. You can go on a slower beat and then you go a lot more, because this is easy for me because I don't have a shoulder pain, but if you're injured, this is going to be very hard for you. So if you can go on a slower beat and you can go beat, 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 beat. So that is, for example, an example for the shoulder. This can be applied to any exercise. You can be doing squats, for example, right? And you have a seat here, or you know how deep you're going to go. And you can go beat, 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 beat. That will address your patella tendon. Another common one that I like quite a bit to use is if you're going to bring a ball, lacrosse ball, an acue ball, or you can bring a sock and roll it up. And you're going to put it in the heel area. And then you can use that as B, 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 B.
I got it playing right now.
And that's the idea behind these exercises, because these exercises are very, these exercises actually work on addressing that rewiring that happened in the brain. So therefore, they're addressing the strength, they're addressing the rewiring. So when you go back to your sport, you have actually addressed all the deficits that have occurred because of the injury or the prolonged injury that you have.
It makes a lot of sense. I know like there's the slides here that also line up to that quite. That's a good point. And then what were the outcomes of that?
They found that the rewiring they measured the EEG, the brave wavelengths when you use a muscle. They found that with these kind of exercises, the actually EEGs, the signals in your brain that activate when this muscle is moving, have changed, have been more presenting with more waves. So it's showing that there is change in not only the muscle structures, because you can measure strength easily, but also how big the spike in the brain waves are. So what is missing though? So like when we talk about research, you always talk about a limitation of research. This is fairly new kind of research, and what's missing is a follow-up. Now, yes, it does change, and they have found that it changed for 4 months. But is it a permanent change, or there's going to be a relapse again? So that's where the beauty of research, right? You research something, and then you have to research more, and we have to wait more and do follow-ups. And so, so this is basically what I have to say in a nutshell. There is more than just a local tissue injury. So we as patients and we as healthcare providers should address more than just the joint and address the whole body. And your concept of the clinic, when you opened the clinic, it was very like it talked a lot about you're not just pumping people out, you're really addressing everything in the body, and it's evident in these lectures that you're showing as well, right? So like you're addressing pain and you're addressing motives, how the athlete wants, how bad the athlete wants to win, has actually shown that it would decrease in pain. It's very connected. It's like a beautiful, complex web intermingled into like performance, and that's our job is. I believe our job is to like address the whole system rather than the joint, and that's why I like this research. It really incorporates everything that we're about in terms of treatment, at least.
Yeah, that's quite interesting. Is Yeah, you got to get the whole body moving, right? Rarely is it, like you said, a single joint. Like that's why I liked a lot of our professors in our program, and I assume many programs is like assess above and below, assess other joints, like see what people's
Exactly.
movement patterns are like, right? So
Yeah.
trying to see how someone's moving as a person rather than, you know, just their injury, which is that's a great point, and something great to drive home is that a lot of patients again will be like, okay, my knee hurts or my shoulder hurts. And then you'll look at other joints and be like, well, let's see you grab a plate off the top shelf or something. And then you see all these other things, right? Like you see how the shoulder can impact the elbow,
Yeah.
or the knee can impact the foot. Like we discussed running last week, how different areas can affect, like distally, so away from the joint it can affect, or proximally closer to the midline. So I think that point of neuroplasticity is very interesting. I guess you could consider, like, you know, strength programs or physio programs should increase that, or should include that neuroplastic component as well.
Absolutely. Yes.
Just the strength, right? So,
Yeah, because strength alone does not address everything, and neuroplasticity does not address everything as well. It
yeah,
is it has to be a combination of both. We have to incorporate it in our treatment pattern as like not like step by step, but kind of like intermingle, combined, and it gets harder and harder with as far as exercise goes.
yeah, it's interesting. I guess it's more of like functional patterns versus, like, you know, single plane strength. Got to do.
Absolutely.
I
Yeah.
guess it has its time and place. Like there's this. I'll pull up this graph or chart here, and then we can talk about that maybe for a little bit.
Sure.
It's like, I guess this is, I wouldn't say an old school approach, but this is kind of like how we think currently. So like if you think about neuroplasticity, you could include that in any step of the program, right?
Absolutely.
And progress that. So you'll have like a separate section for like more of the neuroplastic mechanisms, and progressing that accordingly. I think, I mean, this still does a good job at explaining it. Like it's always reducing pain first, and then starting with, I'd say you'd have like a range of motion component in there, trying to improve pain-free motion, and then to do the strength. So it's like there's no perfect, in anyone's eyes, it's like a rehab progression system. Like we always have these edits that we want to make. So that's a good thing because there's always changes, right? If it was set one way, then you're kind of limited in how you treat.
Exactly. And you're very narrow focused.
Yeah.
And like you said, this is more of a guideline, and we do follow that guideline, and we're just combining different steps and adding more steps to it. That slide you have on is by far one of my favorite slides, because it really, maybe we should just talk about this really quickly, and then I'll officially shut down myself. So if you look at the first one here, you see strength, and this is in terms of rehabbing a tendon, right? So you can see how if you don't do any strength and you don't do any motor control, i.e. these exercises that we've talked about, so that they're taking a passive approach, which is not moving it, or taking an injection in it to decrease the cortisol injection to decrease the pain. What ends up happening is you have a very undesired outcome. So you still have pain, you have affected performance, and you haven't addressed that motor alignment, the rewiring that happened in the homunculus. But B is the traditional method that we've been using right now, or that is being used right now. That's the eccentric for tendons. That is the 3 sets of 10. What ends up happening is you do ignore motor control and motor patterns. What ends up happening is also you have an undesired outcome because you have addressed strength, the muscle is getting stronger, but you always end up with re-injury. You end up with injuries on the other side, because we saw how a tendon affected one side and it affects both sides. Now, again, C is if you only do these exercises and you don't do strength. Strength means a movement against resistance, and it's a progressive resistant increase. So you're not just doing the same weight for forever. You also have like some sort of increase, some sort of challenge and resistance in the form of resistance. So also you have an ability to perform task as like you can move your arm which and every way you want, But if you're not moving with strength, you're not going to produce any power. Therefore, you're not going to get the outcome that you want. So if you're having any sports really, like you have, or any activity, you won't get that effect. This number D, given by the two green ticks, that's ideally the most, the theory behind it anyways, is you do strength, you do motor control, movement patterns to accommodate for the compensated movement that you have engaged in because of trying to get out of pain. And that is ideally and theoretically and somewhat proven to give you a better performance task outcome, where it is you're performing with strength, you're performing healthy, and you're performing with less risk of re-injury.
Awesome.
Yeah.
That was a good explanation. Any other examples of motor control exercises you have?
Absolutely. Like there's like I gave you like the three common ones, but there's a dime a dozen. So that's an auditory external cue. A visual external cue. You can draw a number 8 on the wall, and then you hold a weight in your arm and you trace the number 8.
Yeah.
So that is like you're following something external. It has to be an external stimulus, right? You can go up and down like the edge of the step, like the calf raise with a metronome beat. I like initial injuries, like when you hurt your shoulder, for example. I like ABCs, right? If you have drawing the ABC on the ground, following letters, have any in general, any neck pain, muscle strengthening, you have a laser, and you use that a lot for concussion treatment. You have a laser on your helmet or your whatever on your helmet that you have, and you trace letters on the wall. So basically, it's an endless pit of exercise as long as there's an auditory cue, something that you can hear, a beat that you're following, or a visual cue, a pattern that you're following with your eyes and mimicking the movement.
Okay, that's interesting. Yeah. What about, like, let's say if you're doing like sports specific training, what about, like, for example, balancing on a BOSU and catching a ball? External being somebody throwing a ball at you.
That's an example of an external cue. Yeah, that's like you basically just visual cue and accommodating for that 100%. More of that though, like exercise to pertain to neuromuscular, or sorry, not neuromuscular, to neuroplasticity, the changing of the brain structure. It will be more of like you're standing on a BOSU ball, and someone throws a ball against the wall, and you have to react and catch it.
Yeah.
It has to have some sort of like reactive, unexpected component to it. If you're going to use the visual cue to it.
Okay. So just like random.
Then that's dealing towards like the very sport specific. That's coming very close to specific.
Yeah. So there you got. That's pretty cool because you can have that pretty easily applied to any stage of healing or any stage of rehab. So it's pretty cool. It's nice that model fits in any step of that chart that we showed. Like you said, with the Achilles tendinopathy, the tennis or golfers tendinopathy, patellar tendinopathy, like rotator cuff. So tendinopathy just being an issue with the tendon. So you can apply these concepts to anything. So it actually easy physio perspective wise to work these things in, and it does no harm. So you can actually just try this out and see how it goes. Yeah, I like that because that's definitely more functional than doing exercise in the traditional sense of like reps and sets and stuff like that. Still needed to a certain extent, but you need to supplement it with
That's a good point. It's not bad and it's not wrong. It's just it's incomplete, so to speak, to attain the outcome of that what we're trying to like attain, which is proper tendon health.
Yeah, and that's the thing with like a lot of research with the neuroplasticity, the motor control or motor patterns. That's like definitely a big thing that's happening nowadays. I see quite a bit more of it.
Just to quickly, neuroplasticity, for the people that don't know what neuroplasticity is the accommodation of the brain to change that homunculus. So basically the rewiring, that's what neuroplasticity is. A lot of research is done on stroke patients with neuroplasticity. But then I can geek out about that forever, but just.
Oh yes, we can. As physios, we have the power.
Yeah.
And then like, I don't know, I just get really excited about this stuff. First of all, because obviously I'm a physio. Second is like to have this support from Yehia and like his time,
My pleasure.
his patience researching and his investment into the profession, that like we need more of this kind of thinking in our profession, is to push the envelope a bit and not get comfortable, so to speak, in certain treatment patterns and programs. So I think like hats off to you for doing what you're doing.
Thank you very much. We're back at you, my friend.
And yeah, I'm not gonna let you go yet though. Not that easy.
Hey,
There's
I
still
have nothing
questions.
to do, man. From now to the next 3 months, I'm here.
Well, I mean, I'm just gonna say hi to my friends out. Oh wait, no. A, I don't have any. B, it's social distancing times.
Do you
Yeah,
have any questions? Did anybody pop any questions?
we got questions. What parameters would you then tell patients to use when incorporating these into a home exercise program? Good question, Brooke.
Absolutely. Parameters still, I want to say fatigue,
Yeah.
but it depends kind of question. Like, what stage are they in? Rule of thumb that I like to use: if it causes pain, then you stop. We don't push through pain right now or ever, really. That no pain, no gain kind of mentality is, I personally don't apply it. So is it Brooke? Yeah. So Brooke, if you're prescribing a home exercise for a patient in the clinic, you're gonna see how much they can do. So say they can do, I don't know, let's say 6 shoulder abduction or this movement here with the metronome, and then you're like, oh, it's starting to pain. Hey, you got your 6. I want you to do that 3 or 4 times. There is no research out there, none, 0, that says 10 reps of 3 sets or 4 sets of 12 is more superior than any other way of addressing or prescribing exercise. It's beneficial, but it's not better than anything. So technically, what you're trying to do is if you're trying to rewire a motor pattern, so you want to push the envelope a little, because the brain is going to change unless you are demanding more than it can provide. Therefore, it will start changing. So say, for example, you're doing 6 and your patient is getting tired, and then you're like, you know what, I want you to add another set of 6. And you're like, you know what, I get tired after 4 in the second set. Hey, you're done, right? Do that 2-3 times a day. Again, depending on what stage of healing they are in, depending on the level of athleticism. And then you constantly follow up with measurements of outcome measurements rather, and you see where they're at.
No, it's a good question. And yeah, thank you, Brooke, for always asking great questions. And there will be a treat at the end of this. I've looking for inspiration in many areas, and this topic has provided one. So I'm going to start writing a segment called Physiotherapy and Poetry. So I did make one for today on tendinopathies. I wrote a poem about tendinopathies. Has anyone ever done that? Any of the poets out there, have you done that? I didn't hear anything. They said no.
What's the poem?
So while you think of other questions, I hope this is good. It's really tough writing this kind of book. I like writing poetry, but this is something else. So before I post this, everyone, you're the first. So physiotherapy and poetry. Pain is happening with this tendinopathy. This experience is real. I will not find relief in an apothecary, which is like an old school place getting medicine. I just want this to heal. That's the poem. That's the poem, guys. For anybody, my personal number is, no, I'm just kidding. I'm sorry, that was unprofessional. But yes, that's the first poem of hopefully many. I don't know how I'm going to write them each day, but Yehia gave me that inspiration of tendinopathy, and I was like, you know what? No better day to start when I'm with my brother and fellow colleague. So, yeah, I think those are great points. Great conversation about this. I think a lot of points to drive home is to now supplement these things into programs any way that you see fit. you have issues with tendinopathy everywhere. So it's great to start incorporating it because it doesn't treat your program. It doesn't change your program too much. You just have to change the way it's executed, right? So, yeah, Cillian says great poem. Thank you, Cillian. Thank you. And again, like, keep asking questions. We still have some time, guys. Like, we still have about 10 minutes, so let's take advantage of the time. So if you have questions about anything that was discussed, neuroplasticity, the exercises that you could do, or the healing timeline, or anything to do with healing, let us know, and then we can give you some more answers, hopefully.
So while somebody else thinks of a question, one thing they found in the research that I read that I found really interesting as well is they found that with patellar tendinopathy, tendon pain, patellar is that tendon right here under your kneecap. What they found with jumpers knees and at a time of tendon pain, is they have less variability to land on when you have pain here. You have less variability to land. What that means basically is when you are fully like normal tendon, healthy, haven't injured it, you are able to sustain a dynamic way of landing. You can land at different speeds, you can land on different surfaces, you can land at different forces. But because you have tendon pain, what they found is when you're landing, you're only limited in one or two movement patterns to land in. So you're overexerting that force that is applied to that tendon. That's why one of the reasons why the tendon gets irritating is you're overexerting it over and over again, not using the whole tendon or the different forces in that tendon. So I found that was interesting.
No, it's definitely interesting. It's definitely like a...
And Roots Nest, that's my good friend Paul.
Oh, nice. We got lots of people joining.
Yeah, a lot of people from Toronto and Calgary.
That's why we're getting so many viewers today. I was like, man, I just gotta bring
cool. Kind of a big deal, man.
Can you just be like my training wheels and just come to every every single one to make me look cool?
And Leia's here too.
Yeah, we got a lot of people.
Yeah, a lot of people
tuned in and out. A lot of people from Edmonton too. So thanks, Edmonton, for coming. Oh wait, Vinny Rehab here too from Kelowna.
Yeah, heard a lot about Vinny, man.
Yeah, I definitely. One could say it's like one of my man crushes. Him and Keanu Reeves is definitely. It's definitely great to have all these great physios come on because now is the time to connect. We got time, we got patience. I think it's time to really connect and get together and work on these things together.
Big Brook is asking a question.
So the question is, do you still incorporate eccentric exercise programs?
So, just so we know, the reason why we use eccentrics, because it has shown that eccentrics is actually, it taxes the tendon quite a bit. Why that is important is because if it overloads the tendon, therefore you are challenging the tendon. So technically what you're doing is you are rewiring the brain because you're asking more of a structure than the brain can fire. Therefore, the brain either compensates by putting more structure down or making the muscle stronger. And that's exactly why you have DOMS or like delayed onset muscle soreness when you work out. You're basically ripping these muscles apart because you're lifting more than you usually can. So the brain is like, oh, this person is working the biceps. We need to lay more muscle protein in there. So that's why it gets hypertrophy, gets big after 6 weeks, by the way. So Brooke, to answer your question, you absolutely do incorporate because like as we said, the regular traditional 10 reps or 3 sets and eccentrics, they have been proven to increase strength and decrease pain, which is also very important before you start doing any fancy exercises with eights or metronomes. So yes, to use them, what I'm trying to say is if we can use that and further add on the icing on top with cherries and candles to give you a better cake, then might as well do that. Nobody wants a bland cake. You want like a full with all the bells and whistles?
That's a good question. So still working eccentrics, but also focus on these programs. This isn't like a replacement of everything. This is just like a supplement, or
Absolutely.
consider it. Yeah, that's a good cake.
Yeah.
Oof. Or like the Malva pudding. That's a complete cake to me.
Yeah. The lock and stock.
Lock stock, yeah, lock stock.
Lock stock coffee. Edmonton folks, that's a good spot to be. Not right now.
Yeah, but not right now. Now it's actually they might be doing like takeout or something like that. But that's on. If you guys know where Red Star is on Jasper Ave, like between 104 and 105th. That is a bar that turns into a cafe in the mornings on weekdays. So Lock Stock Coffee is the place to go. And we used to go there quite a bit and have a lot of discussions. So
yes, I can. Somebody asked to forward the research. I absolutely will.
Yeah, I can do that too. I have.
Oh, yes, you have that too.
Jenna, I can send you that link. I think I could send that PDF via Instagram. But in either way, I'll get it to you. You can actually. Sorry.
Okay.
You can DM me or message me or email, and I can just email you that PDF.
Yeah. And if anybody wants more research about anything I've talked about, either contact me or Sunny, and we'll forward it through.
Yeah. So I think we should do this more often. You know.
Absolutely.
I like this. Let's do a segment. We'll call it Yehia's Corner.
Welcome to Yehia's Corner.
Or whatever you like. It's like coming up with names for the garage I'm working out in, my garage. And a friend helped out, and he's just like, I called it the Pump House, which is, I don't know, just didn't have a good name to it. And he recommended the Iron Church. And I was like, sounds pretty cool, but I kind of digress a little bit.
All right.
When I talk about these subjects, I feel like people just stop trusting me professionally. And yeah, for anybody who wants a PDF of my poem, feel free to shoot me a message too. Sorry, that was a good one. So there's still a few minutes. We'll answer some more questions. Other than that, we can banter back and forth. What do you like treating, Yehia? Like, let's talk about you as a physio.
Mm-hmm.
I don't want to say favorite injuries because no one wants people to get hurt, but like, what do you enjoy treating?
Again, like, I don't necessarily enjoy one more than the other. It's more of like, I like the problem solving aspect of physiotherapy. So like, yes, I love like patients coming to the clinic, and we treat the injuries that we see most days is amazing, helping people, all that stuff. But every once in a while you get that one case that kind of like, that does not fit into that, like, I don't know, like the frame of like injuries or expected to see, like, why is that happening? And that's where I go down a rabbit hole of research and find research like this and kind of like, oh, okay, that I get that. What's happening. So
yeah,
I don't know, like, not necessarily one more than the other. I do like how like the movement exercises, sports injuries, because that's where I can like geek out with these exercises quite a bit too.
No, it's cool.
Yeah. How about yourself?
Me, I like shoulders quite a bit, and scapular loading and dyskinesis and things like that. So I like now looking at the shoulder as a stable base, the scapula as a stable base, and challenging it. So people often hear me preaching about Olympic weightlifting. So I like to incorporate that.
Yeah.
Those kind of techniques, not like a full snatch, but those kind of techniques into rehab, because a lot of those, when you break them down, is exactly what the research wants, is that scapular loading. So I like to incorporate those techniques like overhead presses with patients. And like, some people, again, can't lift a band or a dumbbell to the side, but they could do like a 10-kilo push press or like a press.
Yeah, absolutely. Yeah.
And that's more functional than pulling a band. And Shahad, thank you. You do want the PDF of the poem? Done.
No, you don't. Trust me. No.
Done. It's more like a Word file, but I could convert it. Sorry.
So, in regards to what you were saying about the scapula and the shoulder, there's a free webinar put on by Somatic Senses Education.
Yeah.
I think there's on Thursday, if my memory serves me correctly.
Okay, cool.
So if you're interested or any of your audiences are interested, they're putting it on.
That's pretty cool. Yeah. Send me
Somatic
the link.
Senses Education.
Send me the link and I'll post that around as well. So
Absolutely.
still a couple of minutes, guys, for questions. You can ask anything if you like. Anything at all. A few minutes. Poem tomorrow, I don't know. Give me topics for poems.
What do you have planned for tomorrow? What's the schedule like tomorrow?
For this?
For live, yeah.
Live is plantar fasciitis.
Oh,
Kicking foot pain to the curb. So we got that for tomorrow. We got a whole week. So I want people to suggest what topics to do, specific injuries. I want people to tell me what kind of poetry they want on what topics. And I want individuals to say you want to be a part of this. So let me know if you guys want to do this. And Yehia, whenever you're free, come on, come live.
For sure.
May as well talk about things and how do we do things. So, yeah, so any of those things, guys, like make sure you guys ask those questions. Let's take advantage of the time. We're not going to likely have something like this happen again anytime soon. So now that we all have a little bit more time, some of us that, can't really do our day job or night jobs, just let us know what we can do. Cause let's build up our resources. Let's make this profession better in the time that we have. I think there's a lot we can do, and it starts with individuals coming together. Yeah.
100%.
I always end up preaching something, but there's always something good that comes out of bad things. So yeah. I do miss you quite a bit, yeah. If we just go on a sidetrack.
Miss you too, brother.
And
miss you too.
Maybe I'll start that road trip to Toronto soon.
Do it, man.
I'll have to sleep in my car the whole way. I don't want to go into hotels.
You're welcome, Shad.
Yes, no problem, Shad. We should get you on. Oh, we should do our own live of just a roundtable discussion or something about other topics. Awesome job. Yes, thank you, Brittany.
Thanks, Britt.
I can't wait to have you. And it's so cool to do this. I haven't met you in person yet. I've talked to you on the phone, but this is going to be so cool to do.
Brittany is actually a good friend of mine. She's bueno, really very, very good person. Very, very, very good physio. I go to her a lot to pick her brain. So you guys definitely tune in on Thursday.
And for her to take out that kind of time, an hour in the day, huge. That's definitely huge. And I'm very grateful to have that connection, and very thankful to you here to make that happen. So,
my pleasure, brother.
Fun. So, I'll learn quite a few things during that process. So, yeah.
Thanks, Paul.
Pelvic health is amazing. I look forward to it. For sure, it's amazing. Definitely want to get that going in our clinic as well, all the way in Edmonton. So, Brittany, if you ever want to move to Edmonton, you got a job for sure. Wait for us to open up first, and then definitely. If you ever want to move to the way down yonder to the prairies, yeah, I hear it's the new Toronto. Edmonton is so.
Don't push it now, bro.
His the way he's grinning is an agreement. I know him very well. He's a
I personally loved Edmonton. I don't know why people keep hating on Edmonton. I had a good time, and you make the place, man. If you're gonna be miserable and you hate everywhere you're gonna go, no place is gonna be good enough for you. So
yeah,
Edmonton to me is a very, very special place.
I agree. I like it. It's still home. It's where I started a whole new life. So for me, I got to open up a clinic here, and I probably couldn't do what I Pursuit of Motion couldn't happen the way I wanted anywhere else. So this is the starting point, and we'll see where it goes from here. Hopefully, location in Toronto at one point. Cold Lake. Yeah. Oh wow, yeah, that's a little bit